Hello and welcome to another session. Today we are going to discuss CNS examination. CNS examination is one of the easiest thing you will find in pediatrics as well as medicine. The thing, the thing because it looks hard because it is lengthy. Once you find a CNS case, my part I am telling. Once I find a CNS case, I get relieved because CNS the thing is so lengthy that you get ample time to explain to the examiner. In other cases, when you find a respi case, respiratory system, um, by the time at some point of time your the things you explain end and the examiner gets a chance to ask. But in CNS examination, the examiner might not get a chance to ask if you present the case properly, right? So let's study. There is a vast scope of CNS examination, but I have compiled them into some slides that I have taken from various sources. Hopefully, I mean it will help you for your exams to get a better mark, right? So let's start. So pediatric simplified, as you know, I stress upon this many a times. Name, age, sex, place of residence, informant, reliability of the informant. I had told you in the previous class also. Remember by headings, right? So name, age, sex. I have made a slide on what is its significance in view of CNS examination. I mean, why do you'll say, bhai, why do I need a CNS name for a CNS examination? Yes, we need a name. When we the patient says the name, we suspect something from the name. We suspect the feeding habit of the that person. What might be that? All right, we will study it. So name, age, sex, place of residence, informant. No one should forget this. No one. Take the screenshot of this. No one should forget this. Reliability of the informant, presenting complaints, history of present illness, past illness, contact history, antenatal history, birth history, neonatal history, developmental history, nutritional history, immunization history, personal history, history of allergy, optional, right? Family history, socioeconomic status. This should be in the tip of your tongue, right? So, why do we need history? This is a very important slide. So, first we come to name, right? Okay. So, what is there in the name? The name suggests the feeding habits. Once we find certain feeding habits from the history, we suspect any nutritional or metabolic disorders, right? Age. Certain diseases of the central nervous system are limited to a particular age group. For example, most important one is the febrile seizure. Book says 6 months to 6 years of age. The maximum frequency is within the 18 months age range, right? So febrile seizure. In case if it's a neonate, we take the history of HI. What is HI? Hypoxic ischemic encephalopathy. Then if it is older at, I mean the child was normal at birth, up to 5 years the child was normal, then suddenly the child started on seizures. The child did not recognize anyone. The child had altered sensorium. The child was not able to perform its daily activities. We suspect a neuroregression, right? So say certain diseases are X-linked recessive disorders, like your adrenoleukodystrophy. That is the X-linked recessive disorder, most commonly found in boys, right? Place, lead encephalopathy. Mostly, if the person stays nearby a factory, the lead exposure leads to lead encephalopathy most of the times in the children exposed, right? So, endemic infections, the chief complaint. What is the significance of the chip complaint? It is obviously it is significant. The seizures, as explained by the mother, altered sensorium, whether there is a delay, developmental delay, or a neuroregression. Developmental delay is right from birth. Neuroregression might not is, I mean, it's not compulsory for neuroregression to present from birth. The child might be all right till 7 8 years of age, no problem with that, right? So then weakness, headache, vomiting, whatever mother explains. History of present illness, whatever started, whether the onset was sudden, onset was insidious, what was the course, whether the course was far too stormy, whether the course was waxing and waning type. Today the child was all right, tomorrow had seizure, then the child has all right was all right, then had seizures. So what was the course, what were the associated symptoms? Okay. Antenatal, whether we take a history, we ask mother, ma, whether when the baby was in utero, the whether you experience fever with rash, whether you experience increased burning micturition, whether you had any episodes of convulsion. Okay. So in the back of our mind, what is in the back of our mind? It is torch infection, right? Then birth history, history of prematurity or history of birth asphyxia. What history do they give? No cry, no cry immediately after birth. Okay. Developmental history, whether there is a developmental delay or a neuroregression. Immunization history, mostly if the child is incompletely immunized or the child is non-immunized, the child is subject to various infections, and any infection might lead to sepsis and neuroinfection, right? Then immunization gone. Past history, whether the child had similar history in the past, whether the child has any had any trauma in the past and the seizure is because of that. I mean, a cricket ball had hit the head of the child, and after 2 days the child presented with seizures. Now what does that mean? There were some internal bleeding continuing, and when that internal bleeding led to increase in the intracranial pressure, the child threw seizure. Okay. Then or any prior history of CNS infection. What infection we are talking about here? Mostly TB. Okay. When we ask, that's the importance, that's the essence of history taking. Once you ask the normal things now, once you complete the history taking part, you are about 80% near your diagnosis. Other things are just for confirmation, and nobody is saying you to diagnose, sir, this is a case of viral meningoencephalitis. No, never say like that. The examiner knows you don't know. If you know it is a case of viral encephalitis, you might have, there is a high chance that somebody had told you, some PG bhai or didi had told you, or you might have seen something. Okay, so do not act over smart. The examiner knows that you do not know. Okay, you also accept that you do not know. If you can't find a murmur, just say that, sir, I could not appreciate a murmur. If you say, sir, there is a pansystolic murmur over the left fifth intercostal space, so the examiner knows that you are just perfectly copying it from somewhere. So be honest in your examination. Okay, it's okay to not know something at that age. If you appreciate, if you admit that cannot appreciate the sound, or you cannot perform a test, there is no nobody is hampered in that. So drug history, whether the child was on any anti-epileptic or the child had consumed any toxin that led to seizure. Family history, whether there is a family history of epilepsy, whether there is a family history of consanguinity. Why the consanguinity is important? Consanguinity is important because of inborn errors of metabolism, neuroregression. That generally in these cases there is a history of consanguinity. Diet, malnutrition. Children with malnutrition are more subject to increased susceptibility towards neuroinfections, right? Vitamin deficiency, same thing. Socioeconomic status, lower socioeconomic status leads to greater infection risk and greater chances of malnutrition, greater chances of accidental ingestion of substances containing toxins, right? So this slide is very important. 15 points, 1500 things can be found. Gone. Then we come to general physical examination. These all I am explaining totally in the perspective of CNS. When I'll be teaching the RESP part, I'll be explaining the same things but in perspective of RESP. Okay. Then general physical examination. In general physical examination, we first assess the consciousness of the child, right? That is we will read levels of consciousness ahead. So whether the child is alert or drowsy or unconscious. Okay, never miss the consciousness in case of CNS examination. Trust me, CNS examination is easy. Just because I'm teaching or I have taught sometimes, so that does not mean, I'm not saying like that. CNS examination is very easy. the thing is that due to the lengthy part we find it hard, otherwise it is very easy. So look at the posture, whether there is a decorticate posture or decerebrate posture. I will say you what is decorticate and decerebrate with diagram, don't worry. Movement, whether there is any abnormal movement. Interaction, whether the child is interacting or the child is lethargic or the child is irritable. Okay. Vitals, I have taught in the previous video, in the general physical examination part, whether there is fever, bradycardia, hypertension, raised ICP. What is Cushing's stride? Who can say? Write in the comments. What is Cushing's stride? Irregular respiration. Okay. Head. When we had read earlier head to toe examination. Okay. So in head, what we see, microcephaly or macrocephaly, bulging fontanelle. Bulging fontanelle. Remember another question. When does the anterior fontanelle close? When does the posterior fontanelle close? What are the conditions in which there is the anterior fontanelle is wide open and there is delayed closure of posterior fontanelle? These are common questions, right? हो सके तो answer in the comments. Skin, check for any neurocutaneous markers. Neurocutaneous markers are things that are in front of our eyes, but just because our mind does not know, our eyes cannot see. The gaffulate spots, Ashliff macule spot point stain, I'll show you, don't worry. When we examine the spine, whether there is any sinus, any dimple, any tuft of hair. Okay. Then meningeal signs, do the physical examination as I taught in the previous video, but do not forget this. That's why I wrote here CNS focus. Focus is on CNS examination, so we should not miss these sort of things. Okay. Raised ICP. What are the characters of raised ICP? The child will come and say, "Sir, I am feeling raised ICP from the morning." No. The child will come and say, "Sir, I have headache." The child obviously won't say. The parents will say that the child has headache, vomiting, papilledema. Papilledema, you will see the sensorium is altered. So mostly headache, vomiting, right? We suspect the signs of raised ICP. Developmental delay or neuroregression. If you find a history that sir, the child was a normal vaginal delivery, 3 kg, the child did not cry immediately after birth, so we can suspect there is a 100% developmental delay. The mother will say that the child threw seizure on day 1 of examination. The child had no cry after birth. The child was very comatose after birth. After multiple anti-epileptics, the child was revived and was discharged to the home. So we find a perfect history of hypoxic ischemic encephalopathy, so which will lead further to a cerebral palsy child. So there is a definite history of neurodevelopmental delay. That is not regression. In case of neuroregression, the child will be absolutely alright. By the age of 5 to 7 years, the child will throw a seizure without any triggering factor. There will be no fever, vomiting, loose stool, altered sensorium, ear discharge, nothing else. But suddenly the child will throw seizure, and from that point of time, mother will see that the child is consistently deteriorating. The child is not able to recognize anyone. The child is losing milestones. That is called neuroregression, right? So that's a beautiful thing if you read it. Okay. Then systemic examination, hepatosplenomegaly. Hepatosplenomegaly in view of inborn errors of metabolism. You do not need to be an expert in every field. You do not need to be a master of IEM, inborn error of metabolism. Just know the term. Just know the term. You will get to know once you get through it. You will get to know little about it. Then any facial dysmorphism. Okay, this is the general physical examination in view of central nervous system. So we should not miss this. Now coming to CNS examination proper. Okay. In CNS examination, we will be studying CNS examination under these headings, right? Higher mental function. Higher mental function is a very important part of CNS examination. Then cranial nerve, motor system, sensory system, cerebellar, meningeal. I have very carefully made this. I have used some AI. I have used validated books. I have used photos from validated sites, so that it would be very easy for you to understand, to get a photograph of this in your mind. Okay. So in higher mental function, what do we Just a second. Huh. In higher mental function, what do we study? I mean, what do we read under higher mental function? Consciousness, orientation, speech, memory, intellect, mood. We will go one by one, don't worry. And whatever I am saying from now on, remember it very carefully. These are the things that you will explain to the examiner. I have explained to the examiner, you will also go through it. Then we go to cranial nerves. Then we come to motor system. Then we come to sensory system. Then cerebellar. Then finally meningeal. And our CNS examination is over. Okay. Coming to higher mental function, first part. So, what do you mean by higher mental function? Higher mental function, we need to document certain things that comes under higher mental function, so that the general behavior, the like the level of consciousness, attention, orientation, well, whether the child can think, can imagine something, can reason out something, those are the parts of higher mental function. So let's study one by one. First is level of consciousness. So whether the child is active, alert, whether the child is playful, whether the child is responsive to certain stimuli, so that is called the level of consciousness. There are various levels of consciousness. So just a second, I am showing you this. So these are the levels of consciousness. First is the delirium. What is delirium? Clouding of consciousness with attention deficit. So identifying feature of delirium, what is that? Confusion, disorientation, irrationality, and excitability. So just the consciousness is somewhat clouded. There is unclear consciousness. That is called delirium. Lethargy, drowsiness, and disinterest in the environment. These definitions are very interesting. I mean, they are very overlapping also. In case of lethargy, the child responds to verbal calls but has difficulty in maintaining the child will wake up, look at you, then will sleep down. It is very difficult for the child to be in a aroused state. Then obtundation is just increase in lethargy, nothing else. Okay. Mentally dull, blunted, responds only to repeated verbal and painful stimuli. Okay. In lethargy, once you call swastik, the child will respond then the child will sleep. In obtundation, you have to repeat that stimuli. Stupor, state of unconsciousness from which the child can be the child is almost unconscious in stupor state. Okay. So I used to remember like this, DLOSC, something like this. You have to remember anything by making any mnemonic. So DLOSC, delirium, lethargy, obtundation, stupor, coma. Okay. That is those are the levels of consciousness. DLOSC, block something. Okay. Then coma, prolonged and profound unconsciousness. And we know everyone knows the state of coma. Okay. Now not responding even to deep painful stimuli. These are the levels of consciousness. So we do not need to explain this, but we need to know this. In case someone asks, okay, say me what are the levels of consciousness, sir? DLOSC, you remember in the back of the mind. Okay, then sir, delirium, lethargy, obtundation, stupor, and coma. Delirium is the clouding of consciousness. Lethargy, just explain, just understand the thing. You will explain in your own language. You need not say book terms every time. You can explain in your own language, but you need to understand the thing first. Gone. Levels of consciousness. Now we come to attentiveness. What is called attentiveness? The process of selectively concentrating on one thing and ignoring others in the environment. That is called attention. ठीक है. Now how to test whether the child is attentive or not? Observe if the patient is focused without getting easily distracted. Usually child get easily distracted, है ना? Okay. So you in attentiveness, where we test attentiveness? In older children. Okay. Normal findings, attentive throughout. Orientation, we say in elder persons. In medicine, we say the person is oriented to time, place, and person. Okay. I once in a video I said you why we say time, place, and person. Why don't we say time, person, place, or person, time, place. No, there is a particular, this is the particular sequence in which the orientation is gone, and in the opposite sequence the orientation comes. Okay, time, place, person, person, place, time. That is the, that I mean, you must have seen in the TV serials, the eyes, when the eyes get open, the man asks, where am I? मैं कहाँ हूँ? That's a wrong thing. The man should first actually recognize the person in front of him. Okay, so orientation is gotten back in the reverse order, and orientation is lost in this order: time, place, and person. Okay, so how to test for orientation? Ask, who is this person? What is the time? Okay, where are you? I'm the hospital. Okay, place is intact. What is the time? It's evening. Okay, if it's evening, then time is intact. What's the time? Also, this might be approximately 5-6 o'clock. Okay, so this is how we ask. We do not ask objective questions and judge them according to their answers. Okay, gone. Levels of consciousness, attention, attentiveness, orientation. Then speech and language. In speech and language, we test certain things. What is the fluency? The When the patient speaks, when the child speaks, whether the child can fluently explain a thing, can fluently speak a sentence or not. Okay. Then first is the fluency. Then comprehension. Comprehension, whether the child is answering appropriately to your questions or not. That suggests the child is comprehending your questions well. Okay. Repetition. How do we test it? I have a chocolate. The child will repeat just after you, I have a chocolate. Okay, repetition is all right, right? Naming, reading, writing, these are the parts of speech and language. Okay, so mostly important part is fluency, then repetition, then comprehension. Okay, then we come to memory. Memory, what are the components of the memory? Components. Whenever I ask this question, all the students answer, sir, immediate memory, recent memory, remote memory. No, I asked what are the components of memory. I did not ask what are the types of memories. Okay, so what are the components of memory? Registration, retention, and recall. First, the child will register an event, then the child will retain the event. Okay, then the child will recall the event. According to that, we have three types of memory: immediate memory, recent memory, and remote memory. Okay, immediate memory, just immediately recall the things. 1 to 3 minutes. What did I say? I have a what? The child will say, you have a chocolate. You said, yeah, you had a chocolate. Okay, immediate memory is intact. All right. Then recent memory, what did you eat in the breakfast? Okay. Remote memory, how do we test the remote memory? Just think of a question. Imagine that you are examining. Whenever you are watching this video, it's better to be in a group, or if you are single, imagine that you are examining. Imagine that you are asking something confidently. Imagine yourself as a doctor, as an examiner. Okay, then only that, once that mindset comes to you, the confidence will grow. There is nothing that मुझे कुछ नहीं आता, जैसे तैसे करके निकल जाएगा, सबको सब कुछ आता है, बस पढ़ा नहीं हूँ. And I am making this video in for that purpose only, that you don't have to face that difficulty, and you don't have to go through that insult that people without clinical acumen go through nowadays frequently. Okay, remote memory, how will you test? Then oh, when was your school built? These are some questions. When is your was your first birthday? Okay. Then higher intellectual function. What do you mean by higher intellectual function? These consists of general knowledge. You ask some GK questions. Who is the Prime Minister of India? Okay. Abstract. Abstract means you say something, and the child understands that in an abstract way. That is, you say ant bhala to sab bhala. Okay, and the child is able to explain what you said in a context. Okay, that means the abstract sense is all right. Judgment. You ask the child that suddenly fire breaks out, what will you do? The child will say, I will just sit and observe where the fire is going. No, that is wrong judgment. You ask a grown up child that you find 50,000 on the road, what will you do? He'll say, oh, 50,000, I'll just make it side that someone might not run on it. No, 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 these are wrong judgments. Okay, appropriate answers. Whatever we are asking, we expect appropriate answers, right? Then insight, that is judgment. We ask a question and expect an appropriate answer. Any question you ask. Insight, what do you mean by insight? The child, we ask that why the child is brought to the hospital. Oh, what made you bring to the hospital? The child will say, I had pain abdomen, so ma brought me to the hospital. So the child has insight why he is brought to the hospital. Mood and affect. What is? Can anyone say me what is mood and what is affect? You comment below that what मेरा mood सही नहीं है. Is this a correct statement, or we should say मेरा affect सही नहीं है? What is the difference between mood and affect? Affect is the cross sectional view of mood. Okay, I'm giving an example. Let Mr. X, his mom died. Okay, so he is in a state of grief. So his mood is not all right. Now he is going to the meeting. In the meeting, he cannot be in a state of grief. So he is well laughing and presenting things. So his affect is good. His mood is bad. Okay, by this example you might have understood what is mood and what is affect. Affect is the cross sectional view of mood. Okay, so these all combined form the higher mental function. So how to document the higher mental function in Bhaiva? Sir, the child is conscious, attentive, oriented to time, place and person, can speak fluently, has a good memory, higher intellectual functions are good, and the child is comfortably sitting or cheerful and comfortably sitting in the mother's lap. This is called higher mental function. So whatever we read is all explained in a single line. Okay, you don't need to, sir, level of consciousness this, sir, attention this, sir, orientation. No, that does not sound good. You should, at least I said now, you should sound good. The examiner should close the eyes and listen like anything. Okay, or if impaired, so the child is not responding to vocal commands but immediately responds to maximum painful stimulus, higher intellectual functions could not be assessed. Okay, could not be assessed. Now these we read. What is this? I had told you this is called the Glasgow Coma Scale, the GCS. So consists of three components. First component eye opening, second component verbal response EV, third component motor response. Eye opening 4 3 2 1, eye opening spontaneous, eye opening to verbal command, eye opening to pain, no response, there is no zero, mind. Then V, verbal response, the best verbal response is taken. 5 is oriented, 4 is confused, 3 is inappropriate words, 4 is the sounds that we could not comprehend, incomprehensible sound, 1 is no response. Similarly, motor response, you should remember this. Whenever a person comes to the casualty, you are giving final year examination. After this, you will be interns. If you do not know GCS and your internship ends, you are not an intern. Why? When a person comes to the casualty, you first assess the GCS. If the GCS is less than 7, we think of intubation. If the GCS is 10 to 12, we think of increased monitoring of that patient. So GCS is such an important thing. When you say to your senior, bhai, GCS is 12 over 15. Okay, we need greater monitoring of this. So GCS 15 over 15. Okay, we need lesser monitoring. So GCS also helps you in triaging patients who is more sick, who requires more attention, who requires less of attention, and okay, the person is stable. Okay, so we cannot accept a person who does not know GCS. Whatever you do, remember GCS. Okay. 6. Obeys commands. 5. Localizing pain. Just you give a pain, okay, the child might localize wherever you are giving. 4. Non-flexion withdrawal. You give a painful stimulus, the child will do like this only, flexion withdrawal. 3. Abnormal decorticate. 2. I'll say you what is decorticate, oh, don't worry. 2 is decerebrate. 1 is no movement. Okay. These I said: fluency, comprehension, repetition, naming, speaking, reading. These are the things. Okay. Now we come to cranial nerve examination. I said you the 6 parts. First part, higher mental function, over. In higher mental function, that's why I made this. Everything I taught you is here. I made it clear. So whatever I taught you is present here. Higher mental function gone. So we have now completed higher mental function. Now we come to cranial nerves. What are cranial nerves? How many cranial nerves are there? 12. Okay, we will be studying them one by one. Cranial nerve itself is a long type. Once the examiner enters into the cranial nerve, okay, you know your exam is over. Your exam will be over only by explaining cranial nerves. So usually they do not get into them unless and until they find a deficit in the cranial nerve. Understood? So I have I have created a tabular form in which these are the these are the cranial nerves, and these are the components that we examine, and these are the clinical findings in case of nerve lesions. Okay, so olfactory. First cranial, let's start. First cranial nerve, that is olfactory. Olfactory, and the sensory test of how do we test the olfactory nerve? Nose. Okay, so first we make sure that both the nostrils are patent. There is no bleeding, there is no mass, there is no difficulty in respiration in both the nostrils. Then we close one nostril, other nostril is patent, right? We bring a familiar age appropriate substance. So let the child is 4 to 5 years of old, the child must have known lemon, so we bring lemon, which say the child to close the eyes. Okay, first the child will explain the procedure. Always whatever procedure you do, first explain. Once the parents are convinced, they will only help you to perform the procedure, right? So and first you understand what is the motive behind performing a specific procedure. You are performing cranial nerve examination, so olfactory, you want to know both the nostrils. Sense of olfaction is patent in both the nostrils. Over. So we explain the procedure that I will bring a age appropriate substance, a non-pungent substance, to the one of the nostrils, and if the child can recognize it, I'll say that the child is patent. The sense of olfaction or the olfactory nerve is all right. So understood the procedure. Close the eyes, block one nostril, other nostril being patent, bring a age appropriate non-pungent substance near the other nostril. If the child could recognize that, repeat on the other nostril, right? Okay, now we come to optic. In case of optic nerve examination, we usually go under 4 headings: visual acuity, visual field, um, color vision, and fundoscopy. Okay, so visual acuity. Before that, gross vision. How do we assess the gross vision? Or just the child is able to recognize the parents. The child is able to see a dark, deep color, see and appreciate. Test whether the child smiles at mother or not. Okay, these are the gross vision. Then visual acuity charts will be provided to you. If the charts are not there, don't worry about visual acuity. They'll only ask you. Okay. Snellen's chart, Jigar's chart. These two charts are important. Now visual field. Visual field is tested by confrontation method. I mean, we assume first that our visual field is all right. Then we assess the child's visual field. Okay. We close our, let I am closing my left eye, the child will close the right eye, so that both the eyes are closed. Now I bring my hand from distant to near, and I will say the child that bacha, तेरे को जहाँ भी, whenever you see my hand, just raise your hand. Okay. And we, so I'm bringing my hand from this side. The child will say, okay, I can see your hand. Okay, here we keep a mark. Then we repeat it in every 45 degree. Book says we repeat it in any 45 degree. So but we can practically do in 90 degree. I mean, we bring our hand from this side. Okay, here it is visible. We bring our hand from this side. Okay, here it is visible. And from this side and from down. If the side is the same, that we see the object and the child sees the object, then we assume the visual field of the child is normal. Okay, that is called confrontation test. And what instrument we use? Perimeter. The procedure is called perimetry. Color vision, again Ishihara chart will be provided to you. Fundus examination, directly examine the fundus. We do a fundoscopy. We dilate the pupil and do a fundoscopy, right? Then reflexes. What are the reflexes? Direct light reflex. So on the part of optic nerve, okay. How do we examine for direct light reflex and consensual light reflex? Just read the light reflex pathway. Okay, read and tell me in the comments, otherwise I will tell you. That is very important because that is a short question. Also in exams you can find a question short note on pupillary light reflex pathway. First, how do we test the light reflex? Direct light reflex and consensual light reflex. What is direct light reflex? If we project light on this eye, on the right eye, then the right pupil constricts. Okay. What is indirect light reflex? If we project light on the right eye, my left pupil constricts. That is called indirect light reflex. So for that, what is the procedure? First we keep our hand here so that both the fields are separated. Then we project the light. Always carry a torch, a knee hammer, a measuring tape, okay, a pencil, a rubber, a chocolate. Always carry these to the examination hall. Never forget, or never beg to your friends. He is also in need of that. Okay. Then we separate it. Then we project the light. We assess the direct light reflex. At the same time, there is also indirect light reflex. Menace reflex. The fingers are taken towards the eyes. There is a blinking or withdrawal of the head away from the stimulus. Menace reflex. We hit it, then there is a withdrawal. Okay. Clinical findings in nerve lesions, the menace reflex is absent. You will hit it and nothing will happen. Okay. And in fact, if we do multiple times, then also nothing happens because there is the receptors are gone. Then we come to oculomotor. Usually we test 3, 4, 6, third, fourth and sixth nerve simultaneously. Okay, you know one mnemonic, SO4 and LR6. Superior oblique is provided by nerve number 4 and lateral rectus is provided by nerve number 6. Oculomotor. Now testing for nerve 3, rest all the nerves are provided by nerve 3. So there is drooping of eyelids, ptosis, there is dilated pupil, there is divergent squint. So if there is a lesion in the oculomotor nerve, the eyeballs will be down and out. Okay, down and out. Ask the child to follow the objects. Observe the movement of the eye. In first, primary position means your eyes, the subject's eyes, I mean the patient's eyes should look into your eyes. Okay, that is the primary gauge. Then we assess for any abnormality. Okay, oculomotor. Doll's eye movement, turn the head to one side. When the brainstem is intact, the eyeballs will move in the direction opposite to that of the head movement. Remember this is very important. Okay, presence of doll's eye movement indicates supranuclear lesions or an intact brainstem. Okay, so what are the reflexes that come under the oculomotor nerve? Direct light reflex, consensual light reflex, and accommodation reflex. Direct and consensual light reflex I have explained you. So seen in the eye in which bright light is shined. Consensual light reflex seen in the opposite eye in which bright light is shined. Okay, constriction of the pupil is same of the same eye is absent in case of nerve lesions. Then accommodation reflex. What is accommodation reflex? We fix the vision here. Then when we take the object nearer, both the pupils are expected to converge and constrict. Okay, that is called accommodation reflex. If it is happening, then accommodation reflex is intact. Ask the child to look at a distance. Now ask him to look. Okay, whatever I explained on convergence of the eyeballs, constriction of the pupil is there. Okay. Then trochlear, SO4. Ask the patient to look at the nose, the downward movement of the adducted eye. Adduction and downward movement is done by superior oblique. Okay, SO4 gone. Now we come to trigeminal. No, before that we test the sixth nerve. 3, 4, 6 at the same time. Okay, 1, 2 gone. Then 3, 4, 6. See now five nerves you have completed in no time. Okay, abducent nerve, lateral rectus. If the lateral rectus is damaged, the patient is not able to see laterally, there is convergent squint. Okay, now trigeminal is a mixed nerve. There is a sensory component, motor component, and the reflexes. What is the sensory component? Check for sensations all over the face. Okay, these are the sensory components, except for a small area over the angle of jaw, okay. In case of nerve lesions, the sensations are absent. When you take a cotton and just dab here, dab in these positions, and ask the child whether you can appreciate something is you are being touched by something. The child says, okay, yes, I can close my eyes and appreciate that I am being touched by something. Then facial sensations are intact, sir. So trigeminal, the sensory part of trigeminal is assumed to be normal. We explain like that. Then the motor part, how do we test the motor part? Ask the child to chew something and check for the muscles of mastication. What are the muscles of mastication? Masseter, temporalis, lateral pterygoid, medial pterygoid. Okay, so how do we test for masseter? Do not do anything, no need to chew anything. Ask the child to clench the teeth. Okay, when the child clenches the teeth, palpate this area. This is the masseter. Okay, palpate this area. This is the temporalis. If the child can move the jaw to both sides like this, then the lateral and medial pterygoid are normal. Okay, this is how we test for the motor part of the trigeminal nerve. So masseter, temporalis, lateral pterygoid, medial pterygoid. Reflexes, what are the reflexes? Corneal reflex, touch the cornea with a cotton. There is blinking of the eyes. Conjunctival reflex, touch the bulbar conjunctiva with a cotton. Blinking of eyes is present. In case of nerve lesion, they are absent. Jaw jerk. Whenever you say a reflex, always remember the root value. What is the root value of jaw jerk? It is 5, 5. Okay, always write in a paper all the root values, and go for 1 to 2 root values every day. Okay, some things are not difficult. The things are so vast that we get underconfident that we might not remember such a large thing. So in that case, always break them down to small things. For example, one example I'm giving, I'm going a little out of context. In FMT, the okay, I'll be coming back. Let's focus on, or in case of pediatrics, okay, the milestones, the certain neonatal milestones. I just fine motor, gross motor, language, social, all these milestones I'm not able to remember. No, that's wrong. You are not able to remember in a single stretch. But if you break them down to small things, do 5 milestones in a day. Okay, I was talking of FMT IPCs. If you read all the IPCs in one day, Indian Penal Code, you cannot remember. But if you break them, you read 5 IPC each day. In 20 days, you will be a master of IPCs. It's just that we are not breaking a large thing into small parts. Okay. So now come to facial nerve. Facial nerve is also a mixed nerve. So in the motor component, inspection of the face, we look for any furrows, obliteration of the nasolabial fold, deviation of angle of mouth, drooling of saliva. Okay, yeah, inability to of the eyes. We ask the patient to close the eyes so tightly that we cannot open them. Okay, so we tend that the facial nerve, that this part orbicularis oculi part of the facial nerve is normal. Okay, absence of wrinkles on the forehead. So if we say the child to make furrows on the forehead, if the child is able to make, then this part of the facial nerve, this part is being well supplied by both the facial nerves. Okay, ability to blow air, the buccinator is well supplied by the facial nerve. Ability to whistle, deviation of angle of mouth to the opposite side. Okay, we ask the whatever is written in the nerve lesion part, na, just ask the child the opposite of those. Okay, ask the child to make a furrow. Ask the child to close the eyes so tightly that you cannot close them, you cannot open them. Ask the child to blow air like this. Ask the child to whistle. Ask the child to smile. Okay, these are the parts of the facial nerve. Close the eyes tightly, wrinkle the forehead, patient to blow, buccinator, to patient to whistle, orbicularis oris and buccinator, to show his teeth, eversion of the lower lip, platysma. These are the muscles mentioned. Okay, close the eyes tightly, orbicularis oculi. This is the motor part of the facial nerve. I mean, the child can do all types of facial expressions, right? Then sensory part. Check the taste sensations in the anterior two-third of the tongue. Anterior two-third is supplied by the facial nerve. Posterior one-third is supplied by the glossopharyngeal nerve. Reflex. Sucking, corneal, conjunctival. The what is the root value for corneal and conjunctival reflex? 5, 7. Okay. Of jaw jerk, 5, 5. Okay. I mean, afferent, efferent. Afferent is 5, efferent is 7. Okay. Then we come to vestibulocochlear. Vestibulocochlear has two parts, cochlear and vestibular. For cochlear, Raynaud's test and Weber's test. I'm not going deep into this. Normally, it should be positive, that is air conduction more than bone conduction. If negative, then there is a nerve lesion. Weber's test, just you also remember this. Carry a tuning fork. Okay. Weber's test, place the tuning fork over the glabella. The sound will be perceived equally on place it on the glabella. The sound will be perceived equally on both ears. Okay. When both the ears are affected, it is central, and it is lateralized to the affected ear when one ear is affected. How do we test for the vestibular function? Calorie test, you know it. The mnemonic is cows. Cold water. When we do the cold water, or when we put the cold water, there is nystagmus to the opposite side. You just know this. There is practically we do not perform these tests, but these are asked. So sometimes you mug it up, but by understanding. If we understand and mug it up, then it is quite easier to reproduce. So nystagmus to the opposite side. You will see, you will only remember cows, but what is cows? Sir, cold opposite and warm same. What cold, what warm, what is the temperature? They will make you mad. Okay, so sir, nystagmus to the opposite side when we pour cold water. That is that's how you explain cows. Okay, gone. Now coming to ninth, glossopharyngeal nerve. How do we test for the glossopharyngeal nerve? You can test for the glossopharyngeal and vagus at the same time. How you know? Just assess few parts. Glossopharyngeal and vagus, if we combine them, we can go for voice, then swallowing, then palatal articulation, then gag reflex. These four things are being combinedly performed by glossopharyngeal and vagus. Okay. Now coming to individual nerves, glossopharyngeal, go for the sensory part. Glossopharyngeal is a mixed nerve. These are the common things, na. If you don't know what is the mixed nerve, what is sensory nerves, then no, it's already final year. When will you know? Okay. Now coming to the sensory parts, check for the taste. Taste in the posterior one third, anterior two third किसका था? Facial nerve. So posterior one third glossopharyngeal nerve. No one is saying to demonstrate the taste sensation. Just know it. Okay. Then motor part, stylopharyngeus. Just remember it, because see, paralysis of stylopharyngeus is not seen clinically. So we need to remember this. Simple. Reflex, palatal reflex. This palatal articulation. Ask the child to open the mouth and say ah. Okay. When the child says ah, then what do we expect? Because when the child makes some sound like ah, then the particular things that we expect is first is the soft palate rising, second uvula in the midline, third pharynx should constrict. The soft palate should rise symmetrically. The uvula should be placed in the midline, and the pharynx should constrict. These are the findings that we find. That is this combinedly is called palatal articulation. Okay, the soft palate rises, the uvula stays in the midline, and the pharynx constricts. Okay, that these all things happen when the child says like this. Okay. Gone. Similarly, vagus, palatal and pharyngeal sensation by touching the palate. See, I told you na. When the child says ah, note the palatal movements. Palate remains flat or immobile on the affected side if there is a lesion. Okay. Now I am erasing this. Okay, gone. Now, so always examine these two combinedly. So how to combine? Voice, swallowing. If there is a glossopharyngeal nerve damage, the child will find it difficult to swallow things. There will be nasal intonation. Okay, and that's how we test the voice. There will be nasal. The child will be himesh reshmi, right? So the child will find it difficult. So once voice gone, then swallowing, the child will find it difficult to swallow. Then palatal articulation, whatever I said, the uvula stays in the midline, soft palate rises up, then the pharynx constricts. It is palatal articulation and gag reflex. Use a tongue depressor, press the tongue down with a throat swab, just touch the posterior pharynx. There will be nauseating feeling, suggesting that the gag reflex is intact. Okay. Now coming to spinal accessory. Spinal accessory, inspect for the neck muscles, whether there is any wasting or shoulder drooping. Spinal accessory supplies two muscles, trapezius and sternocleidomastoid. Trapezius, how do we test for trapezius? We put pressure on the shoulder of the child and ask the child to shrug the shoulder. If the child is able to shrug the shoulder, then the trapezius on either side is assumed to be normal. Okay. Now sternocleidomastoid asks the child to turn the head to one side against resistance, and the child will turn the head to this side but against resistance. So this side sternocleidomastoid is clearly visible. Okay, clearly felt, not that visible, but it will be clearly felt. In case of muscle paralysis, the child will not be able to turn the head to the opposite side of muscle paralysis. Then hypoglossal nerve, it is a pure motor nerve. So we check the tongue, completely motor supply to the tongue. The tongue should be at rest or during movement. We inspect the tongue. What is the bulk of the tongue? If there is any wasting, any atrophy, the size of the tongue, if it is small, or when we palpate, if there is a small contracted tongue, or a spastic tongue as in upper motor neuron palsy, or a flaccid tongue as in lower motor neuron palsy. Okay. So mostly, if these all are theory parts, if the tongue is completely supplied motor part by hypoglossal nerve, so we check for the size of the tongue, the position of the tongue, the deviation of the tongue, any fasciculations on the tongue. Okay, that's it. This was what I was saying, the confrontation test. The child is closing the left, the examiner is closing the right, and the confrontation test is going on. Okay, this is the right facial nerve palsy. There is loss of nasolabial fold, there is loss of facial, the child cannot frown, there is straightening of the facial furrows, there is deviation of the mouth to the opposite side. So this is right facial nerve palsy. This is how we test in a child. Okay, my left hand, child's right hand closed, then confrontation test going on. This is direct fundoscopy. We use a fundoscope to examine the child. This is the direct and consensual light reflex. See whatever procedure that I had explained, that the same thing is going on. The direct light is projected and the direct light reflex is being examined. Now, ocular movements, accommodation reflex. As the object moves, both the pupils are expected to converge and constrict. Corneal reflex. Whenever you do a corneal reflex, remember this procedure is also risky. Always, whenever you are putting a cotton wisp over the cornea, right? That is a sensitive part. And the child is a irritable substance. Okay, if the child moves the head here and there, there is a chance that you might injure the eye of the child. So always keep a stability of your hand. How to keep a stability of your hand? Place your little finger just over here. Then you can, if the child moves the head, your hand will also move along with the child's head. Okay, so do not put it like this. Always keep a stability here. Then slowly from the lateral side touch the cornea. Okay, gone. This is the jaw jerk. See, 5-5. Afferent efferent, masseter being palpated, temporalis being palpated. See, this is the facial sensation of the trigeminal nerve, sensory part. See, you take a cotton wisp and touch, just touch. Okay, only one area above the angle of jaw is not supplied by the trigeminal nerve. Rest all the areas of the face are supplied by the sensory part of trigeminal nerve. This is the facial nerve. The child is being asked to give various expressions of the face. Closing the eyes so tightly that we cannot open them. The child is laughing. the child is blowing, the child is frowning. Okay, here the child is again smiling, the child is blowing buccinator. This is the Weber's test. This is the Rinne's test. Bone conduction more than air conduction. Sorry, opposite. See what I told you. Glossopharyngeal plus vagus. Voice, swallowing, palatal articulation, gag reflex. This is again summary. Okay. Olfactory, optic, oculomotor, third, fourth, sixth. Then trigeminal, facial, auditory, glossopharyngeal, spinal accessory, hypoglossal. I have made this, why, such that the entire thing will be constricted to a single page. Okay, and you will so that you can find it easier to remember. Take a screenshot. Then we come to motor system examination.